Victoria's Secret's model, breast cancer thriver, Christine Handy with Mullet Champion, Proud Flatty, Sears, Flat Out Secrets.
I'm a flatty. I didn't have implants or anything. And this is Christine Handy.
Hi, Dr. Khan. I'm Christine Handy. I am a breast cancer survivor, a breast implant survivor. I'm a model. Currently, did a big campaign with Victoria's Secret as a breastless model. I've been a model for 40 years, and 40, not 4. And I'm also an author, and my book is being made into a film this summer. I'm also a motivational speaker. I'm on the board of 3 nonprofits.
That's very impressive. You know, that is indeed very impressive. Yes.
So
You're a voice to a lot. Yes.
we really appreciate you coming on.
What'd you say?
I said, we really appreciate you coming on with us, Dr.
Yeah,
Khan.
thank you. Let's just get started. And we know your time is really valuable. So
No, thank you very much. You know, again, I will say this. You know, I just came back from an international conference in Dubai where they had the maximum number of plastic surgeons. They actually broke the Guinness Book of World Records of all the attendees from the 89 different countries. And I will tell you, still in 2023, May, implants are considered overall very safe. And the notion that they have the detrimental effects from the lymphoma / the breast implant illness, along with the fact that they're not meant to be in the body forever, is totally downplayed. And it is amusing and again, frustrating to see that despite what the patients are putting forth along with the FDA and the manufacturers, that is still, unfortunately, if my best friend gets cancer and she goes to the top 100 hospitals in the country, she inevitably will be told that breast implants are safe and this is the best choice and possibly the only choice for her, which is not the right answer. We have to change that thought process because we have to have the patient make that informed consent.
how many of those doctors do you think are getting paid by the manufacturers?
See, ultimately, most of the doctors, if not all, you know, they work for themselves.
Right.
And they are, a good number of them are speakers, you know, especially the ones that go around literally not only the country, but the world, giving lectures on what is, you know, the safe use of their products, i.e. Allergan, Sientra, and also Mentor. Like this meeting was very heavy on Sientra, which is a major implant manufacturer. And the whole drive was that Sientra is safe, breast implants are safe, and this is a very effective way of reconstructing patients with breast cancer and certainly aesthetic cosmetic reconstruction as well. And so the point here is the doctors work for themselves, and this is by far used to be the #1 most common procedure done by plastic surgeons. Again, in 1 hour, a patient with a cosmetic reconstruction augmentation, you can put in 2 sets of implants and be done. So some of my friends have done 6 to 8 of these in a day. And remember, to put them in is very easy, 45 minutes to an hour in a patient who does not have breast cancer. This is for cosmetic reasons. And as you can imagine, this used to be the #1 procedure. Now it's climbing back up again because of the post-COVID. You know, people did not want elective surgery, but clearly up till 2019, 20, right before COVID, this was the #1 surgery done by the plastic surgeons because it is most financially fruitful with least amount of liability, meaning the risks are minimal compared to the nature of the outpatient surgery.
So would a plastic surgeon prefer to do the implant versus an aesthetic flat closure because it's more money? What explain that to me. What's the difference?
So if you will see, most of the cancer patients are done at the hospital-based system.
Right.
So meaning a big hospital, a big institution like the university setting, you know, or a major hospital system in the US, because it's insurance based. Most of the patients are doing it because of breast cancer and the insurance has to cover the costs.
Right.
And that's why you will see most of the patients that end up getting breast cancer are reconstructed. I would say a good half, more than half, with alloderm, which is the cadaveric skin. for the same reason, because the insurance is covering the tab. And then the surgeon is primarily involved through insurance as far as doing the reconstruction. Now, a cancer-based reconstruction always takes a lot longer for two reasons. Number one, you have to depend on that general surgeon to do the mastectomy and the sentinel lymph node. So the plastic surgeon has to, quote, be available and be reasonably available, because the mastectomy could go by fast. If the sentinel lymph node is positive, then you have to do an accelerated lymph node dissection. So that can take some time. So it's not uncommon where some plastic surgeons are waiting for the mastectomy to happen.
Right.
So now, once the mastectomy happens, the patient then has to present into the hospital setting or the plastic surgeon setting in order to get the tissue expander, right? That's well over majority of the patients, because these are large implants. So now every month the patient is coming over. Now remember, this is consuming now from a time management perspective, if you will. And then ultimately then replacing the tissue expander and putting in the likely silicone implant or a saline implant. And then eventually, once that's done, it's not uncommon to do a touch-up surgery, some fat grafting, and then to do the tattooing. So it's anywhere from all these different surgical procedures. A plastic surgeon, such as myself,
That's a lot of money.
I would love to do one quick augmentation and cash without insurance and move on. So my preference would clearly be to take care of the patient who is basically doing it for cosmetic aesthetic reasons versus cancer reasons, if that makes sense now. Because of the setting you're in. Now, I will tell you, most of the plastic surgeons do not like to go to the hospital just because it's a slower process. At a surgery center like this, where I am right now, it's like having your own plane. You get on it whenever you want. You don't even have customs, if you will, like meaning you got your certification from the OR, you make sure that everything is run nice and smooth, and it's on your own schedule, you know, so I can easily add a patient or take off a patient depending on my schedule.
Yes.
So, so just to give you an example, I had a patient that had cardiac issues. Now, when I got the cardiac clearance, this patient is coming from California. And so she already has bought her ticket. So I said, no problem. I'm just going to rearrange. I'm going to start at 5 in the morning. And that way I can do her at the hospital, because that's going to be safer, better, because of her history of cardiac issues. So the point here is, us plastic surgeons, and just like any other enterprise, if you will, you know, we would, and nowadays, the other thing here is, which is very directly involved to your question, no one wants to deal with insurance. The insurances don't want to pay for anything. They pay nothing for anything. You know, just to even do like a gallbladder, for example, or appendectomy, or colonoscopy, just to give you an example at the hospital, you know, or even a reimbursement for the doctor is minimal, in a few $100s. And so even doing a breast reconstruction for a plastic surgeon through insurance, it is, well, I would say, time consuming and not worth. And I will say this, any person who takes any insurance cannot be in private practice. You have to be working for the hospital, where the hospital in itself is doing the billing part, and you're essentially a hospital-based salaried employee, meaning you're not running your own private practice. Because running a private practice nowadays on insurance is, it cannot be even imaginable. You cannot run a private. So for that reason, if a patient says that my plastic surgeon explanted me using my insurance, automatically that equals that the surgeon did a quick job, ruptured the saline implant or removed the silicone implant, left the capsules behind, and was done very soon. You're looking at 20, 30 minutes, because no one is going to justify the 4 hours, for example, that I do in a operating room setting in order to remove the implants.
Now, one of the doctors here in town, he said to me, he said, because I said he's a breast surgeon, and I said, it's sad that they're doing it just for money. And he said to me, not just money, it's also what their idea of a woman is supposed to be.
You know, that is a very deep point that you mentioned. And I will say this very humbly, and I'm not going to speak on behalf, but I will tell you, just going to this conference, for example, and other conferences, the human body, even the male human body, right, in general, now is considered another number, another procedure that's done. Look, yesterday, I removed from a 72-year-old lady with osteoporosis, 650 cc implant each side. Now, I will tell you, just to put on a cancer patient, just to put that volume on that patient and for her to be carrying this weight around, I will tell you, is inhumane. It is wrong. It is wrong for the neck and back and all that strain that her neck and back has gone through. Now, you would think someone would be practical and thoughtful and say, you know what, those are too large for you. No, it's all about, well, I'm going to create the best breast tissue, breast replacement, fat grafting, among others. Same concept, you know, you ask a plastic surgeon, is fat grafting a good idea to a cosmetic patient? Absolutely not, because once that fat dies, which inevitably 30, 40, 50% of the fat is inevitably going to die. Now, when you do the palpation on the chest, the nodules, the fat necrosis is now picked up. And now the patient is anxious. Is this breast cancer? Is this a fat necrosis? Or is this basically a benign mass that needs to be biopsied? And now unnecessary biopsies are occurring in these patients who, for cosmetic reasons, went to their plastic surgeon who said, I will make you look good. But remember, there are ramifications, there are, you know, there's a cause and effect. Now there's a lot of anxiety. This young mom of 3 kids who has had fat grafting and now irregular nodularities on the chest because the body was looked at as merely an object. And unfortunately, there are a lot of, you know, patients who sometimes, given their situation, given the plastic surgeon, how they basically talk to the patients. Look, how many patients you're going to hear directly from the patients? They went in for a tummy tuck and they ended up getting implants. They went in for something and they were told implants, there is a special, why don't you go for it? You hear the many patients that said that they wanted smaller size and they got implants that were twice the size. And they wanted a lift. So this is very common. They wanted a lift and they went in not thinking implants, and the surgeon talked them into getting implants. And unfortunately, the body is looked at as merely an object, unfortunately, and not respected unconditionally, which is what we need to do.
Absolutely.
So your specialty is explanting, is that correct?
That is correct. So just a little bit about my background. I'm a board certified general surgeon. So all these mastectomies, indication for a mastectomy, I'm trained like gallbladder, colon resection, thyroid, trauma, gunshot wound to the chest. I'm trained into taking care of all of that, certified by the American College of Surgeons, the American Board of Surgery. And it's a very rigorous, you know, training for 5 years where you are at the hospital and, you know, you have to perform at a certain level and go through the written and oral boards. Then I did 2 years of burn research during this process, which is not uncommon, where I worked on artificial skin. And then I did 3 years of plastic surgery training where I'm certified by the American Society of Plastic Surgeons. And I'll say this, I worked almost 100 hours a week for 10 years in order to get the training that I did. And this is not uncommon. So 5 years, 2 years of research is not uncommon during the surgical training, and then the 3 years of plastic surgery training. Now, for me, when I started off, I saw very early on, as you can see, a lot of general surgery is mastectomies because breast cancer is that 1 out of 9 women are going to get breast cancer, the most common cancer in women. So we are always, as general surgeons, we're involved in taking care of patients with breast cancer. Now, I saw very early on the patients that got the mastectomies and implants, and when we saw them post, we saw that during this time, the breast implant illness effect, there was not much of breast implant associated anaplastic large cell lymphoma talk. Remember in my training early on, the silicone implants were banned from 1992 to 2007. So during my training, we were only putting in saline implants and silicone under experimental conditions. And there was a lot of talk in regards to the negative detrimental effects given the ban in 1992. Now, initially, if you look at my undergraduate training, I'm a Longhorn at the University of Texas at Austin. So I have training in biochemistry. I'm a biochemist in my undergrad, and then I went to medical school. So I understand the parts per million, the metal toxicity, the composition of the implant, because I took interest in it because this is essentially part of my background training. Now, when I saw these patients early on, and I saw the patients that presented with ruptured implants, silicone leaching, and patients hurting, I said, these are not meant to be in the body forever. They are associated with a lot of problems. Lymphoma, we knew about it early on, and the breast implant illness. So I said to myself, I'm not going to make a living out of doing something that I do not believe in genuinely from my heart. Yes, it is the most profitable way of making money, but I'm not going to do anything. Now, I did a lot as a plastic surgeon, reconstruction of the lower extremity, hand, for example. Remember, all plastic surgeons are hand surgeons. So across the country, you go to Stanford, you go to Mass General, you go to any big name institution, you're going to see the plastic surgeons are taking hand call, for example. So and anyone who can do hand can do anything, because hand is very complex with the nerves, the tendons, and the ligaments, and the bone reconstruction, and a lot of intricate movement. So across the country, plastic surgeons alternate hand call with orthopedic surgery. So now, I did a lot of that: skin cancer, leg reconstruction, artificial skin. Now, my patients then presented, they had implants, and I said, I will only remove them. They wanted me to replace because they were having a contracture or an issue. Now, one after another, even in my training, when I finished, all of us as plastic surgery fellows and who were going to be the new plastic surgeons, we got contracts with Allergan. So you can get implants, for example, Botox and whatever their company would sell, we would get discounted prices, for example, so that we could pass it on to the patients. I chose not to become even having an account with Allergan, for example, because I knew I was not going to do any of this, and that I was going to be a true reconstructive surgeon, because that's where my cup of tea was. Now, very soon, as I saw more and more in 2013, 14, more and more of the talk, no one was even talking about breast implant illness. Now, as I saw more and more patients talking about it, I saw early on that, this is something that I can start doing, because this is exactly why I'm not doing the number one most profitable aspect of plastic surgery. And now I started removing, and then I said, I'm going to start talking about it, and I'm going to start talking about it. And then I myself said, this can certainly be done. Now, no one taught me this, by the way. Now, if you look at any textbook in the world of plastic surgery training, they will tell you that the capsule needs to be completely 100% removed if there is any doubt, suspicion, or concern, or if there is lymphoma. So this is part of our training, but I never removed any capsules in my training. Now, when I started, I realized from the patients and that the capsules and the pathology that the entire implant must be removed and blocked with the capsule, such that anything that is inside is contained, so that if there is a rupture or there is a pus pocket inside, which we have seen from the Facebook Lives that I've done, or fluid, whatever abnormality, we want to be able to preserve that such that we don't let it fall into the chest cavity. And then not only that, the implant must be returned to the patient to show that the saline implant was not ruptured on the way out, or the silicone was very much intact. You have cultures that are done to make sure there is no fungal infection. There are patients of mine that have had fungal infections. They want to go ahead and send the capsule off to pathology so that we know with the CD30 analysis that there is no lymphoma. That is very important to rule out, because you cannot tell by looking at the capsule. There are many surgeons, unfortunately, they say, well, if the capsule is thin, it does not look concerning, I'm not going to go ahead and send it to pathology. That is wrong. no plastic surgeon or doctor or person can say by looking at the capsule with their naked eye that it is pathologic. It has to be sent to the pathologist, where the pathologist who's trained will then do the appropriate stains, and then like the CD30 stain, and rule out BIALCL, squamous cell cancer. That was the other FDA warning. And anything malignant like breast cancer also needs to be ruled out in those patients that have had history of. And I always send the mastectomy paddle to pathology. Anything even remotely suspicious, I send off, be it a lymph node, be it a mass. And we have seen fibroadenoma from my patients who have had no history of breast cancer that was picked up, fat necrosis, histiocytic reaction. And remember, this is very important to rule out by the pathologist. And that, as you will see, I have done 1,000 patients with no drains, without the need for a lift. Now, I have done lifts in some patients during the time of the explant, but these were select patients. And I've been able to do it consistently. And this was the presentation that I did at the ICOPLAST meeting in Dubai from May 3rd to May 5th in Dubai, where I presented my case on 1,000 patients that I've explanted. And so going back to the point, my practice now is solely devoted to explantation. I have talked to patients, like yesterday, I talked to a patient from Hawaii. She is coming in the next few weeks. I have a patient from California that I'm going to talk to, from Florida, literally from every state of the US. I've taken care of patients. Believe it or not, I have a patient that I have to talk to from Japan, and she will be my second patient from Japan. So there are patients who are looking for this knowledge. And again, the goal here is remove the implant, capsule, and any inflamed tissue and get it tested post-op. And this is the take-home message. Your patient should be at peace and should have the peace of mind that there is no capsule remaining behind, and that all the implant, capsule, and inflamed tissue was removed, preferably in the en bloc fashion or 100% total capsulectomy, and that this was tested for malignancy, and that there is nothing pathologic remaining behind. So the patient has the peace of mind that she's going to be good. Just a couple of days ago, this is the worst case scenario. I did a patient who had, for cosmetic reasons, augmentation done, and then she had an explant already done, and the residual capsule was removed by me because she was not getting any better. And this is a young lady in her mid-30s. She needed to get the residual capsules because she had literally exhausted every other avenue. Why was she so sick with the many signs and symptoms of breast implant illness? And we have shown by two ways. Number one, the pathology, and most importantly, the patients who have had their residual capsules removed, that it is vital, it is imperative, it is extremely important to remove that capsule. Otherwise, the patient is not going to bounce back to a normal state of good health minus the toxins. It is incomplete, improper, and wrong to cauterize that capsule on the rib and to state that that is good enough. No, all of that must be removed sincerely, definitively, because that is the true heart and essence of explant surgery.
Right. Well,
How
first
many-
do no harm, right?
Yeah, do no harm, yeah.
First do no harm. Well,
Yeah.
wow.
How many do you see? I've seen some that have mold in them.
Right, so, yeah,
I'm
so,
just like,
so yesterday I removed a set of implants. One was clear, the other one was a little bit brown turbid. So I told the patient, take him home, because she was coach still recovering from the anesthesia. And then I told her, when you come next week, when she comes up for the follow-up, I'm going to, under sterile conditions, take a syringe and basically pull some of that fluid out, and I'll send it off to make sure it's not mold or any bacteria in it. And it is, again, very impressive to see that there is indeed a color difference. Now, maybe I can show you so that your listeners and our viewers can see this. As you will see, there was a clear difference between the two. One was a little bit brown. So if you can see,
Yeah.
maybe. So this is a little bit on the
Yes.
brighter side, and this one, you can see it's a little bit more on the brown side. And so you can see, why is there that difference? Is it on the shell? No, it did not appear to be. It was more the internal contents.
What is it? What do you think that's from?
So I don't think it's betadine. I think it might just be like bacterial contamination on the inside. Now we will see what the
Wow.
capsule shows. We will see what my cultures show, and we will see what this fluid shows, because why is it turbid? Now if you have blood inside saline, right? When you donate blood, you get plasma at the top. So you could potentially have a clot that might have been injected into the saline, and now over time may have become this and oxidized. So that is another differential, but we will see once we do the cultures. Now she had no signs symptoms of any cellulitis or infection, but we will be able to get objective hard evidence. Remember, this is what we're looking for. Sending the capsule off. Remember, there's 3 checks and balances. Once the pathologist looks at the capsule, if he or she sees hyphae, remember back in grade 6, we went and got the mold bread in the back and looked at it under the microscope.
Yes.
And we saw those fungal-like structures. The pathologist is an MD. He will be able, or she will be able to tell if this is fungus or not. Remember, we're doing fungal cultures, and I grossly would see like the black. Now, this is obviously a big red flag. This is not normal compared to the other side.
Right.
But we will do the objective workup, and we'll get to the bottom of it so that we know what it is and what it is not.
You're doing such good work.
No, thanks. I will tell you, see, right now, one of my friends, he's a plastic surgeon. He told me, what you're doing is really like, and he used the word like off. And I said, number one, implants are not safe. If you look at, and again, I brought this journal right here. This is the Plastic and Reconstructive Surgery Journal, right? If you look at the warnings that are listed over here, and let's look at the FDA warning. The FDA warning says 3 things. Number one, the breast implants are not meant to be in the body forever. 10 to 15 years, I say 7 to 10 years. Number 2, the implants, textured and smooth, are associated with BIALCL, the lymphoma.
Correct.
And squamous cell cancer, and the numbers are very low compared to what is published, meaning the numbers are underreported because not everyone is sending capsules off. And number 3, the FDA said that someone has breast implant illness type symptoms, that there is, quote, complete resolution of the many symptoms. Now, these are not my words. These are the words of the FDA. Now, if you look at the manufacturers themselves, like Mentor over here, for example, they will write down all the risk factors. If you look at Natrel, which is, the Allergan branch, you will tell you, the same thing. Patients who are pregnant or nursing should not get implants. Patients who have mental disorders like depression, anxiety should not get implants till they're treated and cured. Patients with an active infection. And then this is also a very important point that I'll mention, and I'm reading here a quote. Important safety information, contraindications, right? Women with active infection anywhere in the body, women with existing cancer or pre-cancer of their breast who have not received adequate treatment for those conditions, and women who are currently pregnant or nursing. Now, this is very important because imagine those patients that have had a mastectomy and they do a sentinel lymph node. Remember, a sentinel lymph node is the first lymph node that drains the breast tissue. If that is positive, then the rest of the other lymph nodes need to be removed. If that first lymph node, the sentinel lymph node, is negative, then you do not need to do that unnecessary dissection. So that helps us because we can use radioactive material and also a dye to pinpoint that sentinel lymph node. Now, imagine I have taken care of, when I was in training, those patients that have had tissue expanders placed These are breast cancer patients, and now they needed chemo and radiation. And now, because of an infection, for example, that they developed, or a wound dehiscence, they did not want to give chemo because of the wound healing properties were now altered, and radiation. And now the patient who needs radiation and or chemo is not able to get the chemo because the chemo immunosuppresses the patient, right? The white count can go down, and the patient now is not getting their chemo radiation because of, for aesthetic reasons, in order to save the tissue expander, which is basically a major problem because the priority is the cancer and not the aesthetics. So going back to the point, now, if you look at over here, again, these are the manufacturer's warning. Other potential adverse effects that may occur with breast implant surgery include, and I'm just reading, and this is on my Facebook page, asymmetry, breast pain, breast skin sensation changes, capsular calcification, delayed wound healing, hematoma, hypertrophic scarring, implant extrusion, implant malposition, implant palpability, visibility, infection, nipple complications, redness, seroma, swelling, tissue skin necrosis, wrinkling, and rippling. And then they mention, quote, this is very important, safety and effectiveness has not been established in patients with the following, colon, autoimmune diseases like lupus and scleroderma. Patients who are diabetic should also not get them. A compromised immune system currently receiving immunosuppressive therapy, planned chemotherapy following breast implant placement. How many patients who have tissue expander need chemotherapy? A lot of them, right? Planned radiation, conditions or medications that interfere with wound healing and blood clotting, reduced blood supply to the breast tissue, clinical diagnosis of depression or other mental health disorders, including body dysmorphic disorder and eating disorders. Please discuss any history of mental health disorders prior to surgery. Patients with a diagnosis of depression or other mental health disorders should wait until resolution or stabilization of those conditions prior to undergoing breast implantation surgery. And again, going back to this, the entire warning is written along with the FDA warnings. And again, this is, if you look at right now, I've told you that there's a possibility for cancer directly associated with the implants, breast implant illness, the many constellation signs, symptoms, the fact that they're not meant to be in the body forever. So if a young lady in her 20s gets an implant, technically, if she lives to the 80s, she should get her implants replaced at least 6 times, right? If it's every 10 years. And this is where I said, with all the problems that I see, it is not safe and wise. And just like you mentioned, do no harm. It's not worth it. That's the take-home message. And one thing that I want to mention, how many ladies do I know that have saline implants or silicone that are afraid to get a mammogram because they feel the hurt? And now, how many millions of ladies who've had breast cancer picked up because of a mammogram, right? The number one reason is a self-monthly breast exam that picks up on the breast cancer. That's the most common reported way. And the second is with a mammogram. And now look, you cannot, once you have these implants, you cannot, for cosmetic reasons, those cosmetic patients who have implants, they cannot do a self-monthly breast exam, and they might be reluctant to going in and getting a mammogram. And so you can see a lot of breast cancer simply not being screened appropriately. And now the breast cancer rates are high. Just yesterday, again, another patient that I talked to from Florida, she had a mass on her mammogram. Now, when I talk to my patients, I tell them, when's the last time you got a mammogram? And they say, well, it's been 7 years, 10 years. I say, I want you to get a mammogram because if 1 out of 8 or 9 women are going to get breast cancer, I don't want to be operating. And the next thing you know, she has breast cancer and I'm dissecting and removing the implant. So just yesterday, that patient from Florida, she said they found a suspicious mass and, they're concerned about, and I said, well, this is just the very first screening mammogram. You have to get a diagnostic mammogram, maybe an ultrasound, an MRI, maybe a biopsy, because you could have benign fibrocystic disease. You could have a benign mass. We need to rule out breast cancer because I don't want to be operating. And the next thing you know, I operate on the right side and the patient has breast cancer. And then I take the same instruments, right? And move them to the left and I could potentially spread, right? We don't want to do that. So any patient that's why I ask, you want to get appropriately screened. And I'll tell you, millions of patients have had breast cancer diagnosed because of a self-monthly breast exam and also a mammogram.
I had just found just the other day the trail warning that you were just reading. I just saw it on Facebook or something, and it has everything on there. And I'm like, how many people that are getting these actually see this beforehand? Do they ever?
I'm not showing anybody the boxes. I mean, if you were putting implants in patients, you probably would, but it's not a fair comparison because you are trying to do no harm. How many of I had implants, I had expanders, I had chemo after the expanders, I had implants, my implant had a MRSA infection. I was never shown the box. Nobody said, here's the black warning on the box. I never saw the box. I never saw the implants until they were inside of my body.
Right. No, I will tell you, I have never augmented except for one cancer patient. And so for that reason, this is where, if you look at so I have only augmented only one patient ever in my life, and this was the cancer patient. So remember, if you look, and I want you to do the check and balance. I want all my patients, any listeners, to whatever I have said, to challenge every single word and letter that I've said. Remember, I'm right now not making up information. I am just being the messenger. What the FDA has said, what the manufacturers have said, I read it out to you. And then most importantly, what the patients are saying, because if you listen to the patients, you will see them screaming in pain and in misery that they're looking for the relief that they need. And going back to the black box warning, no one ever shows that black box ever to the patients because they usually come in the day before if they're on consignment or they're at the hospital. And remember, according to the official FDA mandate, they want the surgeon to actively sit down with the patients and have the patient and the surgeon initialize that he actually discuss the warnings with them. And unfortunately, that never happens.
It did not happen.
That's what I was wondering, like what percent actually goes through that stuff with them?
Yeah.
No, this is where, if you look at, there's two nice ladies in Arizona, for example, they were trying to pass this law, and they did pass it, where the surgeon must actively sit down with their prospective patients, be it cosmetic or cancer patients, so that they acknowledge, the patients acknowledge that their surgeons discussed with them the detrimental, all these risks of what the FDA highlighted. So the patients know, and they have what is the term, informed consent about proceeding with the surgery.
Yeah, we need all the states. Why? Yeah, why we need to work on that. I'm sure you're talking about Robin Taub. She's an amazing woman.
Yes, exactly. She's a wonderful lady. Yeah.
Unbelievable what she's doing to help the community. And
Absolutely.
so are you. And so are you. Thank you for being so honest and for coming into this space and saying this isn't right. That takes a lot of bravery and courage. So thank you from a patient perspective. Thank you. Because unfortunately, I can't tell you how many times I tried to revise my breast after breast cancer, and ultimately the breast implants, I have a concave chest now. And had I just gone aesthetic flat closure, I would have gained years back of my life, years. So
right. No, every time surgery is done on the body, and as you will see, the breast cancer patients, remember, every time you go in and operate, the tissue expander, first the mastectomy, the long operation, and possibly the axillary lymph node dissection, the tissue expander. Now, remember, well over half of the patients have alloderm, which is cadaveric skin, as an internal bra that holds. That in itself has a lot of problems too. That's not benign.
Is it like mesh? You mean like the mesh?
Yeah, that is the mesh. So that's cadaveric skin that's used in order to hold the heavy implant such that it doesn't fall down over time.
Because you have no tissue. Yeah.
Yeah. So it really works very effectively. And, the purpose there is to hold. Now, a lot of patients basically want to know what that is. And I know I will be able to show that, just 1 second.
Is that mesh toxic too?
No, it's used in hernias, amongst other patients. So as you can see, this is a nice picture. As you will see, you see the white
Yeah,
mesh. It works as a
Yes,
cadaveric alloderm mesh that
yes.
supports the implant and the muscles at the top. And so
So
the
like a
implant,
sling?
yeah, the implant is supported by this alloderm at the lower 1/3, if you will.
Okay, so that's, people shouldn't be worried about the mesh.
Yeah, they should not be, because again, this is cadaveric skin. It has been
Got it.
basically it's the antigens, which is basically what the body recognizes as foreign. They've been removed. Now, sometimes there is cross reactivity to it, meaning the patients can develop kind of a red, like a reaction to it, if you will, because it's not the patient's own native skin, but the antigens, meaning the body that recognizes it as foreign, those elements are removed, so the body truly doesn't mount an immune response. But I will tell you, I'm not a big fan of it, simply because once I have to remove that alloderm, there is the alloderm then that sticks to the skin, and it can get very, very tricky to dissect off of the flap, which makes my job and post-operatively much harder. The other thing that it does is the muscle then window shades up. And so now you have muscle up at the top and no muscle at the bottom, which causes more of the concavity effect, if you will.
Yeah, that's.
I have a good thing you said that about the mesh, because I have that for a sling for my bladder and for my hernia that I had, because my plastic surgeon, I didn't do implants because I have MS. And I was like, I don't want that foreign body. I didn't know anything about BII because it was 9 years ago. And but I ended up, he talked me into, when he removed my dog ears, I did a lymph node transplant, and he talked me into a tummy tuck, which wasn't a tummy tuck. And I got a scar, and he, they just talk you into all this stuff. And I was dumb and didn't know better and just was like, yeah, let's do it.
See, I will tell you, we all have been patients, this is us patients, myself, whenever we go, we have utmost reverence for the MD, for the doctor with the white coat. This is how we all grew up, right? From when we were kids, this is how our parents raised us. Now, sometimes when, in some cultures, believe it or not, they look at doctors as God, literally without any exaggeration. And
Doctors think
like
of themselves as gods.
yeah, now I will tell you, sometimes the surgeon's ego is the worst thing on earth, because you can never penetrate that. But right now, what we're looking at is, we're not looking at a question. We know this is 100% evidence, right? There is no denying the fact. Look at the fact that in 1992, the implants were banned. Now, this is the other problem right now. So the implants were banned, and they reintroduced the implants in 2007 as the gummy bear safe cohesive implants. If you listen to Dr. Henry Dijkman out of the Netherlands, he and I are going to do a Facebook Live next week. You will see, I agree with him wholeheartedly, completely, because I see it clinically, grossly. The gel bleed occurs from silicone implants from day one, and also saline implants as well, the intact saline implants. And that slow leaching gel bleed of the silicone from that saline implant and also the silicone implant causes this reactivity. After some time, the breakdown occurs more often and significant, to the point where the effect of the breast implant illness becomes very noticeable, or the implant starts breaking down. Now, in some patients, it's a good number of patients, it's a silent rupture. Now, going back to the point here, the gel bleed is responsible for that silicone toxicity. If you look at the composition of the implants and the silicone shell of the saline implant, that is enough to impart the same set of problems. So as you will see, those patients that have saline implants, they have the same set of problems as patients with silicone implants, and they have the same set of problems with ruptured silicone implants, meaning you cannot differentiate between these three groups of patients. And the point here is, all implants are bad, including the post-2007 cohesive gummy bear gel implant, because they cause the same set of problems. The gel bleeding occurs. Yet it's newer technology. It sounds better, gummy bear, right? More cohesive. But in reality, at the end of the day, it's the same problem. Silicone leaching into the periphery and causing the reaction.
How many people do you think get breast implant illness from them? I mean, I only know a very few that don't have issues with their implants.
See, this is a good question. Now, one way to gauge is to have the patient fill out that questionnaire where you have those 55 or 55 of those symptoms from the 11 different organ systems. Now, let's look at this a little bit more meticulously detailed way. The breast implant illness affects every organ system of the body, every cell of the body, because remember, it's traveling in the blood, right? Now, hair follicles to the migraines, vision problems, dryness, throat dryness, trickling, endocrine problems, tinnitus, ringing in the ears, sinus problems because of the dryness, neck and back pain, fibromyalgia issues, cardiac issues with arrhythmias, right? Palpitations, very well established. Patients with silicone mastitis. You have patients with breathing problems, difficulty breathing, anxiety, panic attacks, not able to take a deep breath, GI disturbances, endocrine issues, reproductive issues, early menopause. You have many patients, and you will see this was in the MD Anderson study from 2018 with patients with stillbirth that were reported higher than the general population, right? 4.5 times. You have patients with plantar fasciitis, bladder problems, UTIs, rheumatological joint problems. That's another hallmark feature, brain fog. Now, so I have all these symptoms, that are listed 55. Now I have the patients check each one of them. Now there are patients, believe it or not, that came to me and said, well, I'm an ICU nurse. I don't have any problems. I just want to get him out because I am going to get pregnant and I want to breastfeed, and I heard a lot of bad things and I'm meant to be in the body. Now she comes to me post-op and she says, wow, I can think so much better. I have no more joint pain. I got a lot more energy. My 12-hour shift is not a burden. Now there are many patients like this. Look, the 72-year-old lady that came to me, do you not think that her doctor told her that she has early onset of Alzheimer's if she has brain fog or if she's got joint pain? Guess what? By definition, you have osteoarthritis at 72. No, I don't care, just given the age. Now, yes, you're going to have endocrine issues. For God's sake, you're 70. But guess what? She checked off all those boxes. And believe it or not, if you put the whole story together, she knew deep down within her heart that it had to be more than her baseline age of 72. And time will only be witness to the fact. And I say this to you and to the rest of the world, to the plastic surgeons, to the FDA, don't listen to me, listen to the patients. One of my friends is a plastic surgeon in Philadelphia. He told me, Khan, what you're doing is dangerous. I said, I like you. You're wishing well for me. You're looking out for me. And I said, what's the point? He's like, well, you're doing live telecasts like I did one today from your operating room. And you're talking about a topic that's, if you group 100 plastic surgeons or 1,000 plastic surgeons in a room, 999 will flat out deny and say, what are you talking about? Well, I will say two things. Number one, all what I'm doing is removing the implant and the capsule and just making sure it's not lymphoma. I'm not hurting the patient. And I said, don't listen to me. Listen to all my patients, 90% of them or more. They're very happy. They are so relieved of the many symptoms of breast implant illness just from the mechanical weight of the implant sitting on the chest. Mm-hmm. And this is where he said, well, you got me. No one can touch you. And I say this, I'm not doing this to kind of prove, trust me, financially, I would be a whole lot better. Whatever I have, I will have 3 off. Just last week, one of the other patients said, well, you've got a nice niche for yourself. I'll tell you, even right now, I would love to put in an implant. And trust me, it is not only the time, 1 hour, but I will tell you physically, and I'll say this, it is a lot of burden on the body, my neck, to be wearing the headlight because I have to have that vision and my loops, and to be wearing a mask for literally 8, 10, 12 hours per day, sometimes 16, to be operating. And when I do operate, now this is a very important point. I've never highlighted this, but I will mention this, in a horizontal incision. So I'm always looking under like this. Now, there are some surgeons who actually have said, make an incision up and down from the nipple areola down. And I'll tell you, that's a big mistake. Now, this is a very important point that I've not mentioned before. Now, imagine you're looking at the breast tissue and you're making a cut from the nipple areola down. You're cutting the nerves, the ducts, you're putting a scar right in the center of the chest, and you're more fixated on a lift. And me, majority of the times when I'm making, I always 100% of the time make that horizontal incision. And when I make that horizontal incision, I make it a point to be directly below the muscle. And when I'm below the muscle, I always remain below the muscle so that I don't disturb the breast tissue above the muscle. Because remember, this is the anatomy: nipple areola, breast tissue, muscle, pectoralis major, implant, rib. And so just like the breast cancer patients, where a vast majority of them are below the muscle, as soon as I make the cut, the horizontal, I'm always below the muscle, directly on top of the implant, directly on that avascular plane, operating like this, such that I'm able to remove the entire capsule. Remember, that's the whole gist of this surgery. I don't touch the breast tissue. And this is where, when I cut out that excess skin, along with the recoiling of the skin, most of the patients, 80% of them, do not need a lift for that reason. And I'm able to kind of do a pseudo lift, a vector up, as I move the tissue inward. Now, versus an up and down incision, yes, it is easier for the plastic surgeon to operate because you're looking straight down and you're kind of opening a book. But to be able to dissect the capsule directly off of the rib on the inner medial side, it is impossible from an up and down incision, because you have to go parallel to the rib. And I will tell you, the access that I have with the horizontal incision is the best. And the vertical up and down incision that cuts through the skin, the scar of the chest, the nipple areola, skin, nerves, and ducts, one should not violate that. And yes, it may allow for a surgeon to have easier surgery and to be fixated on doing that lift 100% of the time, which is wrong. The lift is not always required. Like I said, 80% of my patients are very happy. And so to be able to dissect in that horizontal plane, it is physically very hard on the neck to be able to dissect. And
Yes.
I'll tell you, if 100 surgeons want to attempt to do the surgery that I do, I say this very humbly, a good 50% will outright refuse to do it because of the way, how physically, mentally demanding it is to be able to operate with your neck turned to the side.
Wow.
I-
Oh.
Go
So
ahead.
not only from a physical perspective, from a financial perspective, because you would rather do at least 3 augmentations in the
Yeah.
time you do one, because if you have 2 operating rooms like I do, you can easily bounce between 2 rooms and do 6 to 8 augmentations in a day. Between a physical perspective, which by the way people do routinely, you have physical perspective from a time perspective. An explant takes 4 hours. I book every patient for 4 hours. On Tuesday, for example, I did the cancer patient, the 72. I took almost 6 hours, 5.5 hours to do. And then also from a financial perspective, you're taking a hit compared to just putting in the implants. And the patients need to realize that for a surgeon who's board certified by the American Society of Plastic Surgeons, who is not augmenting, that's a big deal. And that, if you ask me, validates, authenticates, and makes this professionalism to another level, to the supreme level, because you know that this person has put the do no harm and the ethics and the values number one, and is not about fixated about doing what is the most financially, and time consuming and least physically demanding procedure.
I have to personally say thank you. I mean, it didn't affect me personally, but I founded a group called Flat Out Love of just flatties after breast cancer. And you've actually operated on quite a few of my friends. And I just have to say thank you for doing what you're doing.
No. I will tell you, no, you don't have to thank me. And I appreciate you saying that. It means a lot. My patients, I have a true bond with each one of them. And my patients understand this. I have no other vested interest in my practice, in my career, except to help the patients. And I will tell you, for me, if you look at, quote, my lifestyle, you will be very much surprised. I don't have a fancy house. I don't have a fancy car. I don't have fancy shoes. If you look at my coats, they're pretty much, I wash the same regular, meaning and the point I'm trying to make here is I am doing no harm. I'm helping, and it's a privilege and an honor to do what is the right for the patient. And if the patients were given a chance, they would do likewise to others. Remember, the goal here is do unto others what you would like done to yourself. And this is the whole premise behind humanity, about respect for the other person, for the
Exactly.
other family member, be it about the friend, because you know what? This is what makes us strong.
Yes, exactly. Well, thank you. Thank you
Yeah.
so much for what you're doing. It takes a village, and someday I hope that people are shown the black boxes. I hope people make different choices about their life, not for vanity, but for health.
So thank you.
Thank
No,
you.
no,
Thank
you're
you for
welcome.
your
No, you're
time.
welcome.
Thank you for your time. And I have people ask me all the time, who's an explant doctor, and I can't wait to recommend you. Where are you located?
So I'm in Michigan, Novi, Michigan. And so if you type my name, you will be able to see me on Facebook. Now, I want to say this to your listeners.
Yeah.
Right now, my goal is for my patients to not make a decision. You want to go on a listening tour. You want to listen. You want to preferably do 3-5 other phone consults or in-person consults with your plastic surgeon and see what's inside their head. I can do only so many of these.
Right.
I'll tell you, I have at any given time, do the phone consults, because I always the limiting factor. I filter, talk to my patients. You want to be able to have that peace of mind, so you know without a doubt. Look at that other patient that I mentioned. She had the residual capsules. You do not want to be like that patient.
Yeah.
Who
Absolutely.
basically talked to her plastic surgeon, and she was told that I will get the capsules out. And she said, my plastic surgeon said the capsules were so thin, they were benign looking, and they did not look concerning. And so I left them behind. You don't want to be, you want to have your surgeon who actively talks about it, who acknowledges breast implant analysis. The one problem here is the vast majority of the plastic surgeons, unfortunately, don't want to even utter the word breast implant analysis. They don't want to even hear it.
They don't want to be
Yeah.
associated with it.
Yeah, they don't want to, because they're going to deter many of their other patients who are coming in for cosmetic reasons,
Right.
So you want to be able to talk to a plastic surgeon who, number one, accepts, and on social media nowadays, it's very healthy to talk about it. I'm sorry. And you should only go to someone who's talking about it, because you do not know what's the secrecy behind him not talking about it. So he should openly acknowledge breast implant illness exists. Number two, what is the goal of the surgery? And this should be clearly written down on the consent form, because that's the legal bind between the patient and the surgeon. 100% total capsulectomy and en bloc fashion, or 100% total capsulectomy. And to get this checked for pathology, cultures, pictures. I myself take high definition pictures of the chest, showing the video and the still high definition pictures that all capsule is removed, and me cutting opening off the capsules. And then to have that absolute firm belief that if the capsule is not removed, the patient is not going to bounce back to a normal state of good health. And that is that firm comfort and smooth decision you should be able to make, such that you have that confidence in your surgeon, so that when you put your head on pillow that same night and the next night or 3 weeks later, that you know your surgeon believes in it wholeheartedly. And your surgeon should not be augmenting. Your surgeon should be a board certified by American Society of Plastic Surgeons doctor, because that is the only one true board that authenticates and certifies true plastic surgeons. Otherwise, there are a lot of surgeons out there who unfortunately want to be able to, basically take out implants. Now, this is that American Society of Plastic Surgeons, this logo with the kind of two semicircles, if you will, one larger than the other. This is the board certification. You should see this on your surgeon's website. No plastic surgeon who is, American Board of Cosmetic Surgery is not a board. They cannot come and practice in the hospital. They will never do a cancer patient ever in their life. Those patients will be given disservice because they're not trained properly. General surgeons, ENT surgeons right here in town, they are not board certified. They have their own private surgical suites, and they're doing these type of surgeries. I myself, for example, I mentioned I presented to the whole Plastic Surgery Society, and I presented to them my data about 1,000 1,000 explants that I have done. Now, I'm very happy to share this. Now, remember, this was a very controversial topic. Some of the plastic surgeons were not happy at all to see this was even quote accepted for presentation as an oral at one of the largest, or excuse me, the largest forum for plastic surgeons in the world. And the point I'm trying to make here is that we have to raise the awareness, and there are many surgeons who will learn, and my job is to not only share this with the patients, but also with the other plastic surgeons, so I can share with them how I do it in the manner that I do. So choosing the plastic surgeon is key. And the best, and you heard all of those other points, and one of the best ways to validate this is to talk to the surgeons, all patients, and to ask them the questions about how was your journey, what were the expectations, how are you feeling, how is the course, is your surgeon actively talking about it on the Facebook, so that there is no doubt in the patient's mind as they sign up. That patient that I talked to from Hawaii, believe it or not, a couple of weeks ago, she bought her day and she paid for the surgery without even talking to me. This is the bond that she had because she knew from her research that this is the commitment. 11 hours away she was going to fly for her surgery. And this is what you want to be able to have and reproduce in your surgeon, so that you have that peace of mind, like I said earlier, that you have that utmost confidence in your plastic surgery.
Good for you. Wow. Thank you.
So, we really appreciate you taking the time to be on here with us and answer some of these questions, because, there's a lot of it that you mentioned that I didn't even know. So, it's just.
No, thank you. Thank you. I will tell you, I find that, this is, I talked about a lot of details, a lot of specifics. I say this to you, and like I've said to the other, groups, please take this as stage one. Next time you come on and have your viewers, please write questions down or ask me extempore so that I can answer the questions. You can bring it on and I'll be able to, because I will tell you after some time, the same set of questions will repeat themselves. And one person, now we're not looking at and talking about just in the US. We're talking about the rest of the world, and that was important for me so that I can share my data. I want to say that, we are as human as any other person on earth, and the hurt that we feel as Americans, the person from Australia, she wrote to me, and again from South Africa, for example, or this lady that is living in Japan, she's going to be coming and I'm going to do a phone consult. So what we want to be able to do is share the data so that the patients can make a reasonable, sound decision about what is the course of action that they're going to take, and that they have the peace of mind and they can get their individual questions answered.
Awesome.
Yeah.
I'm so impressed. Thank you so much, from somebody that's really been harmed by implants. Thank you so much.
No, you're welcome. I wish you the very best. Thank you so much. It was a pleasure and a delight to talk about breast implant illness. And, I will end with this. The heal is real. There is a real problem, and there is a real, I use the word cure.
Yeah, it is. Yeah. Knowledge is power too. Thank you.
Yes, absolutely. Take care. Bye-bye. Thank you.
Flat Out Secrets with Christine Handy and Sears.